Welcome to another EduMed video, and in this video, the second of our proning series, we'll talk a little bit about how proning improves oxygenation and CO2 clearance. Before watching this video, I'd really recommend watching the first one in the series, which was talking about how proning works and the physiology and the mechanics behind it. We'll be building upon those concepts in this video here. So we'll touch a little bit about respiratory mechanics, but then really concentrate on how proning may improve oxygenation and also how it may improve CO2 clearance. Now, this video is based on a fantastic review that was written by Gattinoni et al. It was published back in 2013, but I think the core principles still hold true today. I'd really highly recommend you go and read this paper. It's only a few pages long. It is quite in-depth and a lot of detail in each sentence, but it's worth reading a few times, and it's certainly one that I crack out every so often, just to refresh my knowledge of proning. Just to remind you of what proning actually is, it's where we're turning patients onto their front, so rather than having them being nursed on their back, we turn them over onto their front. And by doing so, we are potentially having deleterious effects on chest wall mechanics with reduced compliance, however improving diaphragmatic excursion by reducing intra-abdominal pressures. Through a number of mechanisms, we're potentially improving oxygenation and CO2 removal, and that includes the so-called theory of shape matching, improving VQ matching, and improving lung compliance. Again, please go back and watch my first video on proning to get a lot more information about this. Overall, proning seems to be very good for ARDS, and it's something that we should be doing fairly commonly for patients who have severe respiratory failure. And in later videos we can talk about the evidence for the use of proning and the clinical trials that have been produced, such as the ProSEVA trial. If you're interested, please leave a comment in the section below if you want to see this video, and I'm happy to produce that. So let's think a little bit first of all about oxygenation. Now, the main reason we think that patients are improving their oxygenation is through better lung recruitment in the prone position. If you look back to my first video, we talked about how more of the alveoli are opening up when patients are placed face down. And that's because the apices of the cone model are being pulled open, and therefore you're getting less collapse at each segmental section of the lungs. And as the blood seems to be quite homogeneously moving through lung and doesn't really change much when you move from the supine position to the prone position, the fact that we're opening up more alveoli but keeping the blood flow relatively the same in terms of its regional flows means that we're automatically going to be improving VQ matching. In addition to that first video on proning, it's really worth going back and watching my series on the basics of ventilation, where I go through in quite a lot of detail what oxygenation depends upon, what CO2 depends upon, and I think that's vital to really understand when moving on to thinking about these advanced methods of managing patients with severe respiratory failure. Now, the reason I've put in brackets the movement of blood to aerated lung is the fact that all of the studies tend to suggest that blood flow doesn't seem to vary when you put someone in a supine position compared to a prone position. But certainly anecdotally, I think all of us who have proned enough patients have seen those patients that seem to respond very rapidly in the same way as if you've got a patient with quite significant basal disease when they're nursed in a supine semi-recumbent position, and then you lie them down flat and suddenly their oxygenation improves. And that is almost certainly due to blood flow going into the middle and upper lobes and not having to work against gravity, or conversely increasing up their noradrenaline levels, increasing their cardiac output and therefore their pulmonary blood flow, and therefore improving oxygenation by getting more blood into the upper zones. So I suspect there probably is an element there of matching of aerated bits of lung to promote blood flow into those bits, And certainly in a lot of patients what we see is basal atelectasis and disease and relative sparing of the upper zones, which we're going to then be preferentially putting blood into by turning them into the prone position. CO2 clearance is a little bit more complex and really actually quite an interesting part of proning. What we often find is that most patients improve their oxygenation when we turn them onto the prone position from supine. However, CO2 clearance seems to be slightly different. In those patients who don't get an improvement in CO2 clearance, i.e. their compliance, lung compliance doesn't improve, they tend to do quite badly overall, and there is a link between mortality and being able to clear CO2 better in the prone position. That link is not there with oxygenation. I think that's probably due to the underlying mechanics of the lungs being so bad that by proning the patient we're not improving compliance and therefore we're not improving CO2 clearance. Now, in ARDS, where you've got pneumonic lung, what's essentially happening is that you've got alveolar destruction, pulmonary edema, and a drop in VQ matching. And for all of these things, you're going to impair CO2 clearance. By proning a patient, what we're doing is we're recruiting up more alveoli, so we're getting better aeration of the blood and therefore more utility of the blood to remove its CO2 as it flows through the aerated parts of lung. And probably the most important thing is the improvement in lung compliance. Again, go back and watch my first video where we talked about the deflated alveolus, the semi-inflated alveolus and the hyperinflated alveolus. And I fully suspect that a lot of the improvement that we see in lung compliance is due to just having less overdistension of lung units and less atelectasis. With that uniform alveolar distension, all sitting within the steep upward slope of the compliance curve, we're just able to change the volume of the alveoli for a much smaller driving pressure. And as such, increase tidal volumes, increase minute ventilation, which is the main function of causing CO2 clearance. So, I think in summary, by having all these different mechanisms for causing that allow proning to improve ventilation and oxygenation, there are multiple ones and they're probably all working in tandem. I don't think it's a matter of one theory being right and the others being wrong. It does seem to improve your oxygenation, and if you do get a reduction in PCO2 for the same ventilator settings, it's usually quite a good indicator that your lungs are still remaining relatively compliant, that you're getting good perfusion, and the lung function itself is actually adequate. If you don't get that, then be worried this patient may not do so well. If you found this video helpful, then please like and subscribe to the channel. If you hit the bell notification, then you'll get an update when the next one comes out. Thank you very much.